What are we looking for further? Let's take a look at what we've done already. What did we discuss with PR interval? Shortened. What does that mean? Less than 0.12 seconds. What other components do we have of WPW? Well, the next two are going to be combined. On that QRS complex, you're going to have something called a delta wave or a slurred wave on the QRS complex. And once you form that delta wave on the QRS complex, understand the QRS complex actually widens. So the only thing that you're going to find widened or prolonged in Wolff-Parkinson-White will be the QRS complex. The PR interval will be shortened and you'll have a delta wave. You put those three together with pre-excitation syndrome, you cannot miss this. But it begins with understanding the foundation. It's with knowing that you have an accessory pathway pathology. If you take a look at this ECG, I want you to take a look at the lead at the very bottom, and what you end up finding is exactly what I just said. With your delta wave, widening of your QRS complex, and a shortened PR interval. Let's take a look at management of Wolff-Parkinson-White. Now, it's just as important that you pay attention to how you wish to control your rate and such with arrhythmias. It is just as important, sometimes if not more, to look out for those drugs that are contraindicated. Why is the big question. For example, up until now, we've pretty much seen verapamil, your calcium channel blocker, being used in every single type of SVTs. They included AFib, atrial flutter, and we had multifocal atrial tachycardia. The Digoxin, the first time that we've seen that really not being used or not preferred was multifocal atrial tachycardia. These drugs were used as being antiarrhythmics because it slows things down in the heart. But why is it that in Wolff-Parkinson-White, all of a sudden, even though you want to control and manage and you want to cardiovert, end up being contraindicated? Because how many pathways do you have in WPW? 2. One is the physiologic normal AV node, and the other one is the pathologic and no delay characteristics. So therefore, if you were to block any impulse from passing to the AV node, what have you done, ladies and gentlemen? You've now forced that impulse to go through the pathologic pathway and exacerbate the condition. No other, so far, SVT has an accessory pathway like what we've seen here with WPW. You want to avoid calcium channel blocker, digoxin, and to a certain extent, adenosine as well. These are the drugs in which if you block that AV node, you're forced to go into your accessory pathway, and you don't want that. That must be understood. So if that's the case in terms of the medical cardioversion and some of these drugs are contraindicated, then what choice are you now left with? Well, you're left with a couple. You have electrical cardioversion if the patient is hemodynamically unstable, or procainamide infusion if stable. Now keep that in mind. Why would you think about even using procainamide in a patient that has an arrhythmia? Well, procainamide is a class 1 drug. Stop there. Class 1 antiarrhythmic is a sodium channel blocker. And you have 3 subtypes of class 1, 1A, 1B, and 1C. 1C is relatively simple. Flecainide is what you're thinking, perhaps, and it does not distinguish between which gate of the voltage-gated sodium channel. What does that mean? Now, flecainide can either, or class 1C, can block the activated channel, or it can block the inactivated channel. When you block both of these gates of the channel, then your sodium channel, for all intents and purposes, is completely rendered dysfunctional. Wow. If you don't have a voltage-gated sodium channel, how in the world are you going to have what phase? 0, right? Phase 0 of which action potential? The one with the plateau, 0, 1, 2, 3, 4. That's the mechanical one. So if you can't have phase 0, how in the world is the heart supposed to pump? It doesn't. Are you worried about sudden cardiac death with 1C? Yes, you are. Let's talk about procainamide. Procainamide is 1A. 1A. Use the A to advantage because that A then represents, to you, the activation gate of the sodium channel. That, normally speaking, at RMP, let's say at approximately negative 90 resting membrane potential, what does your sodium channel look like? Close your eyes. Think about what it looks like. The activation gate is closed. and the inactivation gate is open, is it not? Where's my inactivation gate? How important is that? Really important. It's facing the inner side of the membrane, the inner side of the cell membrane. Well, that activation gate gets open when it gets triggered and sodium rushes in. That's where procainamide works, okay? Procainamide is a 1A class in which it blocks the activated channel, A and A. Use this as a cardioverter if your patient is hemodynamically stable. If not, electrical cardioversion, WPW, is what we're talking about. What are the three major components? You begin with PR interval. Shortened or prolonged, please. Shortened, what does that mean? Less than 0.12 seconds. Good? Move on. QRS complex. Give me the two components there. One would be the delta wave, which is a slur, and the widened QRS complex. 1, 2, 3 for WPW. Do you ever use digoxin? No, because then you're forcing into accessory pathway. Now, definitive treatment is ablation of the accessory pathway. Is that clear? These are important steps for management. What drugs to avoid at all costs, what kind of cardioversion, depending as to the status of your patient, and then definitive therapy, get rid of it. Get rid of the accessory pathway, ablate it. Now, with our other supraventricular tachycardia, I'm just going to mention a few things here. Now, we have something called AV nodal reentry tachycardia, and we have atrial tachycardia. I'm not going to go into great detail about AV nodal reentry tachycardia at this juncture, but atrial tachycardia, SV and SVT, would then mean that the P waves are increasing in number, right? Increased heart rate. And all that picture is showing you is another type of reentry of AV nodal. At this point, I would consider this to be a little bit too much detail, but nonetheless, I've placed it here so that you understand, ladies and gentlemen, that not only could you have something like Wolff-Parkinson-White syndrome as an accessory pathway, but then as you further along into your education, you'll learn more about these reentry tachycardias. Why not be prepared versus being shocked? On your own time, you may take a look at this. Let's continue.